Good afternoon, sir.
Yeah. Is it okay if I handle the slides today?
Yeah, sure. So when your turn comes, I'll hand it over to you, Mr. Raj.
Okay, fine. Thank you.
Sure. Thank you, sir.
Dr. Riju, good afternoon, sir.
Good afternoon, sir. Good afternoon.
So good afternoon, everybody. So welcome to today's online Friday free webinar. And so today we're going to deal with the topic surgical site infections, the practical strategies for everyday surgery from incision to complete recovery. And before getting into the webinar topic, so I'll hand over to Mr. Rajaraman, General Manager Marketing from 𝐒𝐿𝐴, to take over for the introduction part.
Yeah, thanks, Stella, for the kind introduction. I hope you can see my screen.
Yes, sir.
Yeah. Very warm welcome to all participants. Thanks for joining in today. So today is a very special day. We are celebrating Children's Day across India, and also WHO has announced November 14th as World Diabetes Day. And we are so fortunate to have Dr. Riju today to take us through with the diabetic foot ulcer prevention and all that. Okay, just a quick introduction about 𝐒𝐿𝐴. We have a long 135 years legacy. So we are a company focusing on infection prevention over the years, right from the founding days in 1889 till today. Okay, just a quick question. So some of the participants who have attended last week's session, so it's just a true or false question to you. Healthcare associated infections affect both high and limited resource setting. What is your take? So you see two pictures of one limited resource and a high resource setting. Of course, we need to understand that both the chances of infections are quite high, but the degree of infections vary between these two centers. They say almost a high resource center has half of or less than half of a limited resource setting. So this is something we need to understand. So currently, you must be going through a lot of media news reports, and they say that we are living in VUCA world where there's a lot of volatility, uncertainty, ambiguity. AI is coming. Okay, the policies are changing. So a lot of things are happening. Is relevant for healthcare? Yes, definitely, it is also relevant for healthcare. What we need to understand is that the regulations will get more and more stringent. The policy makers, the insurance companies, all those forums will get more agile and vigilance will increase. The patients we can see furthermore being vocal, not just on what people are doing today with their experiences. So if the system is making it fragile, how as healthcare workers we can become agile? That's the series about. If you have to deliver patient care in the best possible way, innovation and continuous learning is important. We have to embrace adaptability, evidence-based decision making, collaborative decision making. All these are important elements which we will have to go through, and as professionals, I think we need to undergo. And that's the reason why at 𝐒𝐿𝐴, our concept is just not providing the best in class products. So we, apart from providing the products, we also support on the on-site customer services and training sessions where we collaborate with organizations like 𝐒𝐿𝐴, Inflexon, SkillsforMed, Somaya Medical Healthcare University. then this 𝐒𝐭𝐤. These are some of the collaborations we have where we partner and bring about high quality scientific engagement for skill development of people. Coming to this series specifically, we call this as a 555 series, where 5 Fridays we have 5 thought leaders and who will be sharing their success story, what they have implemented in their specialities and their institutions. So we are fortunate today to have Dr. Riju Ramachandran, who heads one unit of surgery in Amrita Institute, Cochin. And he specializes in wound care therapy. And this is so coincidental that today, as the WHO wants to raise awareness on World Diabetes Day, and this year's theme is about diabetes across all life stages. So at 𝐒𝐚𝐥, we are actually trying to promote awareness on diabetic foot ulcer because there is a high prevalence of hyperglycemia, a lot of issues related to um, uh, contributing to diabetic foot ulcers. So basic one thing which we need to understand is check before becomes the problem becomes too complicated. So cleanse and protect. And these are some statements which we keep reminding people. So coming to this series again, this is we have 5 thought leaders, like you see the ad on mutual fund sahi hai. So like this stalwarts engaging with the umpire to say that start early and they motivate him or train them. This is exactly what we are going to. And this is some picture of a recent incident which is happened in Chennai, where there is a hurdle race where 70 plus people join hands together and they're jumping and crossing it at peace. So our job is not as complicated as what you see the 70 and 80-year-old jumping through the hurdle race, but we'll have to do the basic things extraordinarily well. And that's what this series is about. When we learn from masters, how do we implement it on the ground? So with that, I think I thank you and welcome all of you for the session. Over to you, Stella.
Thank you, sir. So let me take you all through the quick introduction of SkillsforMed for the benefit of the newcomers who have joined for this webinar today. So about us, we have been established since the year 2018, and we have been providing comprehensive training program for all the healthcare professionals. And we have 10,000 plus healthcare professionals who have got benefit out of us, and 75 plus hospitals are networked with us, and 50 plus course topics have been launched. And so with this 10,000, we want all the new joiners who have come to the webinar to join our community and become a part of a growing community of healthcare professionals who are enhancing the skills and build confidence and, transform your patient care with the updated standards. And about our SkillsforMed learning pyramid. So it has 4 stages. The stage 1, which talks about the service excellence skills, for example, infection prevention, control basics, communication, professionalism, and like where you learn all the basics which is very essential to survive in a healthcare industry. And in the stage 2, where we transform the nurses from the competency level to the clinical expert level, that is talking about the core patient care skills. All the procedural skills are discussed there. And in the stage 3, from the clinical expert, you can transform yourself as a specialization nurse. For example, we have the 𝐒𝐼𝐶N infection control nurse course program and clinical instructor program and ER upskilling program and so on. And once you have become a specialized nurse, it's time to look yourself in the leadership journey. So in the stage 4, we offer 2 kind of advancements, where it's a vertical growth or the lateral growth. Vertical growth, which something you see like you become in charge, so supervisor and A nurse and nursing superintendent of the hospital or the CN of the hospital, where also it's your choice to become a CEO of the hospital, looking yourself transforming a career as taking up a lateral path, which is like stepping into the administration level in the operations department. So this is all about the SkillsforMed learning pyramid. And I have an announcement which is like about the infection control nurse course program. So this is actually collaboratively given with 𝐒𝐿, and there is an offer sale which is running. Here is a QR code. At the end of the webinar, again, I'll showcase this QR code where you can grab this opportunity and enroll into this program. And equally, you can see the wall or the course leaders for this program. And also, we have seen many nurses who have taken up this course, who have transformed their career from the bedside as an infection control nurse. And to know more details about our course and website, you can contact Ms. Jayanti, who's our admin manager. Her number is on the display. And also you can visit our website, which is mentioned here, which is www.skillsformed.com. As Mr. Rajaraman have mentioned earlier, so this is a webinar series which is running, and today we have a speaker, who is Dr. Riju Ramachandran Menon, is a professor in the Department of General Endocrine Surgery at the Amrita Institute of Medical Sciences, Kochi. He serves as a faculty for medical education and the infection control certification program, and is an active guide for DNB, MS, and PhD scholars, in addition to being an examiner and reviewer for several national and international journals. His clinical expertise spans intravenous procedures for varicose veins, deep vein and perforator surgery, endocrine surgery, advanced wound care, podiatry, and minimally invasive surgical techniques. He also been an investigator in multiple major projects related to nanotechnology-based wound dressings. And Dr. Riju has an extensive academic footprint with over 80 publications, 15 textbook chapters, and several authored books, and including works on chronic venous disorders, thyroid and parathyroid surgery, wound detection systems, and ethical legal aspects of medical photography. He is also a recipient of Young Achiever Award for his pioneering work in 4D bioprinting for diabetic foot ulcer healing. He is an active member for several national professional association, and in addition, he is proficient in multiple Indian languages. And we welcome you, sir.
Thank you.
And yes, and also we have Dr. Parivalavan Rajavelu, who is a highly respected consultant surgeon, and he is a visionary founder for SkillsforMed, and also he is a deputy medical director for quality and patient safety in Sundaram Medical Foundation. He is a passionate advocate for healthcare quality, and he plays a key role in 𝐒𝐿. He contributes as a mentor, national speaker, GC committee member, and serves as a chair of EndoSafe, actively promoting endoscopy across India. And his leadership is deeply rooted in extensive clinical experience, ongoing research, international presentations. Through SkillsforMed, he continues advanced healthcare outcomes by equipping the professionals with real world skills and practical knowledge. Dr. Parivalavan's unique blend of clinical skill, academic rigor, and system level of thinking makes him an inspiration and change maker in today's healthcare landscape. We welcome you, sir.
Thank you, Stella.
Yes. So over to you, Dr. Pari.
Thank you. Can you move to the next slide? Before moving, I thank Dr. Riju Menon for coming on to, in spite of his very busy schedule, to give this lecture, and also 𝐒𝐿𝐴 for generously sponsoring the session. So I just don't want to take time, just 5 minutes, just to highlight the burden of surgical site infection. It is about 11 to 30% in developing countries, that is the low and middle income group countries. Whereas in sharp contrast, the developed countries, the West and the other developed countries, have a very low incidence of surgical site infection, about 2 to 5%. So this is something, as a limited resource country, we have to be very aware of, and we need lectures like this to educate ourselves how we could actually reduce this incidence. So this is, of course, we have infrastructure gaps, we have reduced capacity to fight infections, but still, I think, as we will see, that surgical site infections are largely preventable. Next slide. So the evidence is almost 2/3 of surgical site infection can actually be prevented. both the CDC, WHO, and other international guidelines repeatedly tell us that 2/3 of infection, that is, if you have 100 patients with surgical site infection, that means you have missed the chance to prevent infection for 60 of them. That is the whole truth about surgical site infection. And these infections causes enormous patient suffering, sometimes mortality, extended stay, and costs. So therefore, if you prevent, we can prevent all these. And this is possible only through consistent implementation. Theoretical knowledge will not help. We need to implement it at the bedside for the patient. Next slide, please. Now, how do you prevent SSI? The answer is actually pretty simple. You need to follow SSI prevention bundles. These are evidence-based practices, and we need to implement them together. And then only they will reduce the surgical site infection. All elements need to be used, and compliance is very, very critical, not just checking the boxes. You need to actually practice it and implement it. And these are all standardized. They're not high tech or anything like that. Most of them can be done even by the lowest resource hospitals. That is the real tragedy about this. Next slide, please. Now, I think I missed a slide. Just go back.
I'm sorry, Doctor.
Yeah, please move it. Okay. I'm not going to go, click once again, Stella. Yeah, I'm not going to go much in details. I think Dr. Riju will cover all this, but just to say, SSI bundles cover, sort of span the whole length of the stay of the surgical patient, preoperative, operative, and in postoperative. So I just given some few examples, but I'm not going to go into detail. Just to say that SSI bundles will cover the whole length of stay of the surgical patient. And next slide. This is the most important point I wanted to make in my small introduction. So this particular study of colon SSI bundle, which came almost nearly 6-7 years ago, very clearly showed that if you actually implement just one bundle, you may reduce it by about a small percentage. But if you use all the bundles, you can see the reduction of the SSI from 17.5 coming all the way to 2% when they implemented all the bundles. I mean, all the components of the bundle. So there are 6 components, like preoperative, bowel preparation, and many other things. Again, we don't want to go into detail. My point in this slide is that if you're going to only implement randomly 1 or 2, you cannot expect results. You need to implement as much as possible of these bundles, then you can radically reduce the surgical site infections. So that is the message I wanted to tell before Dr. Riju enlightens us more about this topic. Over to you, Dr. Riju.
Thank you, sir. Today, I'd like to thank the 𝐒𝐚𝐥 group, Pari sir and Mr. Rajaram sir for allowing me to speak on this topic today. One of my favorite. I am actually a part of the infection control certification program at our hospital. And this is something that happens at least I think once in 3 months, the program happens. So this is something I keep delivering on and off. So I'll be talking about this topic. Can I share my slides? Am I visible?
Yes, Doctor.
Yeah. So today is World Diabetes Day, and I tell you all a happy Diabetes Day. We hope that the world starts doing things to prevent diabetes, prevent complications from diabetes. One of the most important being the diabetic foot, which actually causes a lot of morbidity for people. So this is my hospital here. I bring greetings from Amrita Institute of Medical Sciences, Kochi. So for this session, our objectives are to classify surgical site infections as per the CDC criteria. We'll try and identify risk factors in surgical patients. We'll try to implement some evidence-based strategies in preventing surgical site infections, apply some management protocols, and try to integrate practical strategies into surgical practice. So these will be our learning objectives for the day. So like Parisar just pointed out, the surgical site infections, they are causing a huge economic burden to our economy. A simple hernia, if the patient comes to the hospital under general anesthesia or spinal anesthesia, the patient goes back home in about a day or two if everything is all right. But if there is an infection, instead of 1 or 2 days, the patient will be in the hospital for the next 7 to 10 days, maybe additional days, additional surgeries for removing a mesh or infection, for antibiotics. It phenomenally increases the cost of surgery. Additionally, when there is surgical site infection, they will have pain, psychological impacts. It is said that more than 60% of surgical site infections are preventable if evidence-based strategies are incorporated into practice. So the CDC actually classifies surgical infections into 3 categories based on depth. It is superficial incisional, deep incisional, and organ space surgical site infections. The superficial incisional surgical site infection, it involves the skin and subcutaneous tissue. And by definition, this should occur within 30 days of the operative procedure. It manifests with all the signs of inflammation, that is the pain, redness, swelling, fever, and also sometimes with a pus discharge. The deep surgical site infections, unlike the superficial, they can occur up to 90 days because some of these deep surgical site infections, they may be associated with an implant which may be kept in the body. So it can occur up to 90 days. It involves the deep soft tissues like the fascia and muscle. And here, there is no surface features. It is all more systemic, like fever, abscess formations, and there may be a dehiscence of the wound. In the organ space infection is a third type. It involves the part of the body that was manipulated at surgery. This is the most serious part. The first two are possibly more easily treatable, but the last one may actually cause more morbidity and mortality, like an abdominal abscess or mediastinitis, very dangerous conditions. So this is a surgical site infection divided into 3 types and what each part means. The CDC has also classified the wounds. Any wound that is there, it is classified into a clean wound, clean contaminated, and dirty infected wounds. On the right side, you can see the risk of surgical site infections in these patients. So if it's a clean wound, generally these are all surgeries involving the skin and the soft tissues alone. There is actually the respiratory or GI or the gastrointestinal tracts are not entered. So here, the risk of surgical site infection is very less than 1 or 2%. And the CDC itself says that in such a patient, there is no necessity for a preoperative antibiotic. So many of my patients who come for a thyroid surgery or a breast surgery or hernia repairs, they don't get any kind of antibiotics. They do the surgery and go back because these are all clean surgeries. A clean contaminated surgery is when there is controlled entry into the respiratory tract, GI tract, or the gastrointestinal tracts, like a cholecystectomy or a non-perforated appendix. But in a clean contaminated case, there is a significantly increased risk. You can see it is more than 2 to 3 times the risk as in a clean contaminated, clean wound. So it is 3 to 11% surgical site infection here. Now, this is the set of patients where a pre-operative prophylactic antibiotic helps in preventing wound infection. The class 3 is the contaminated wound, where, like in an open trauma or a major break-in style technique, like in a perforated appendix, fractures, etc. Again, the risk is increased, almost double that of the clean contaminated. But unlike the clean contaminated, when you have a contaminated or the next one, the class 4 dirty wounds, we do not think of prophylactic antibiotic, but now the antibiotic that you give becomes therapeutic. It needs to be continued for the next few days as per the protocol for the antibiotic. Now, when you are assessing patients pre-operatively, you will have to find out what is their risk of developing an infection in the after surgery has been done. So based on patient factors, we have two sets of factors. One is the non-modifiable factors. The other is the modifiable patient factor. The non-modifiable are something which you cannot change. Age of the patient, gender of the patient, the genetic factors affecting wound healing that the patient is born with. Now, these are things which cannot change. As you see that with increasing age, there is a almost 2 times increased risk of wound infection. The modifiable factors are the ones that we can prevent. So whenever we see a patient in the OP and we are thinking of doing a surgery for them, we have to work them up for control of these things. So these become the preventive factors. You can actually control it and then do a proper surgery. So modifiable factors like diabetes, if the patient is diabetic, definitely there is a 3 times increased risk of infection, is what is said. Obesity. If you're doing a procedure for a patient, say a hernia, and the patient is obese, it would be wise to tell the patient to wait for some time, reduce weight, and then come back, because otherwise there's a more than 2 to 3 times risk of wound infection. Smoking has a 30% increased risk of infection. That increased risk is multifold because of the low blood flow that occurs in these patients, the reduced immunity that happens in these patients. All these can actually increase the chance of wound infection by 30%. Malnutrition, immunosuppression, etc. Now, there is one other set of patients. See, most of our wounds, they are the source of infection is the skin itself. So there, it's the staphylococci, and it can be, by preoperative preparation, it can be cleaned up. But what happens is some of these patients may have an MRSA, and such a patient, if present, there is a 5 times increased risk of infection, especially if it is a nasal carrier. The surgical factors for infection are maybe happening in the preoperative phase, during the surgery, or after the surgery. So preoperatively, it is the prolonged preoperative hospital stay. Earlier, many of the patients would be admitted in the hospital for a week before surgery for workup, for optimization of the patient, etc. Now, that actually increases the risk. Now, the tendency is more for daycare surgery. The patient comes in the morning, gets admitted, operated, and by evening goes back. Now, this is a phenomenon called ERAS, enhanced recovery after surgery. Now, this is coming up in a big way. Skin preparation, again, preoperatively is a problem. It is very well known. And if the wound is not cleaned, or if the patient is not washed and cleaned surgery, high risk of infection. So if the skin is prepared well, the chance of infection is less. One of the things that we do always when we are working up a patient for surgery is to see if there is any infection remote to the site of surgery, any minor infection even. If present, it needs to be controlled. It may be a minor cough, or it may be a small pustule somewhere in the body. But if present, it needs to be cleaned before you can think of doing a surgery. Hair removal by shaving is an absolute no-no. It has to be avoided. Now, the intraoperative preparations are key Hypothermia. Again, there is a 3 times increased risk of surgery if hello.
Yeah, Dr. Riju, in between the network connectivity got lost, I think.
From where was this?
No. This slide is there, and intraoperative discussions are going.
Okay. No, intraoperative. From where?
It is just a couple of seconds.
Yes.
It's all right. No, just proceed.
Yeah, we can. I think still he has a network issue there.
Yeah. Again, no, your voice is not heard. Hello. Your video is also paused.
Hello.
Hello, Dr. Riju. I think your video got paused and no, we couldn't. We lost the connection, and your presentation is also not seen. Can you hear me?
Hello.
Yes, Dr. Riju.
Hello.
Can you hear me? Stella, can you just call him and talk to him? Do you have the number?
Yeah, let me.
Hello.
Dr. Pari, we are fixing it up, Dr. Pari. I'm on the call.
I request the audience just to be a little bit patient. We're trying to fix this up. Please, wait. Apologies for this problem. Can probably ask him to come by a phone, and if you have the slides, you can share.
He'll be joining back in a while.
Okay, fine.
Hello.
Yes, Dr. Riju, can you hear me?
Yeah. Is my screen visible?
No.
Doctor, if you want, I can share the screen. Okay.
Yeah, it's
Is it
visible.
visible?
Yeah, it's visible now.
Yeah. So sorry. I'm so sorry for this. Yeah. So the comprehensive SSI bundle that Parisar was talking about. So this consists of 6 pillars for SSI prevention. It is the patient preparation that happens, the antimicrobial prophylaxis that happens, skin preparation, intraoperative measures, surgical techniques, and the post-operative care. So the patient preparation essentially is pre-operatively, where, like we said earlier, it is sugar control, smoking cessation. In fact, our hospital is a no smoking zone. We don't allow any kind of smoking because that is a very bad thing for wound healing. Nutritional optimization. It is now called the ERAS, the Enhanced Recovery After Surgery, where people go for early feeding, minimize the amount of fasting that is there, and decolonization protocols. The next is the antimicrobial prophylaxis. It is good to select an appropriate agent. We'll be talking about it more. The correct timing is about 60 minutes before incision. And what is more important is there should be an appropriate dosing. And when required, there should be a redosing also. The third thing is skin preparation, preferably chlorhexidine alcohol. That is what is recommended now. Others are also okay, but what is recommended is the chlorhexidine alcohol, and no hair removal unless necessary. Because many of these patients are admitted unnecessarily for preparation where they shave the patient from head to foot. That is not needed. What is recommended now is the use of clippers just to trim the hair at the site of surgery. No razors, because if you clean with if you shave with a razor, you can cause micro abrasions, which can invite a surgical site infection. The fourth measure is the intraoperative measures, maintaining normothermia. Hypothermia actually reduces immunity. It can reduce the blood flow, cause defective healing, and increase chance of wound infection. So maintenance of normothermia in the patient is an absolute must. Though for the surgeon's satisfaction, that the temperature in the OT needs to be kept cold. Glycemic control, again, maintaining the sugars around 90 to 120 would be very, very good. Oxygenation intraoperatively is a big requirement, and sterile technique. The surgical technique recommended is gentle handling of tissues, because otherwise there may be hematomas, there may be tissues which are damaged, which can again act as an nidus for infection. Meticulous hemostasis is absolutely necessary, and dead space elimination. So many of us actually go for keeping drains just to keep to avoid this dead space from appearing, and appropriate closure as necessary. Post-operative care, wound protection. Generally, a non-permeable dressing is kept for about 48 hours, and after 48 hours, the wound dressing is removed. So the patient can be allowed a shower after 48 hours, by which time epithelialization would have happened. So most of these regular wounds, they heal by primary intention, and in the first 48 hours, the edges of the two edges, it approximates by epithelialization, and there is no, it acts as an effective barrier for any other thing to go back inside. So you can tell the patient to take a shower after that time. Glycemic control, again, the post-op is very important. World Diabetes Day, this is what we keep saying: preoperatively, intraoperatively, and post-operatively, all this is as part of the enhanced recovery after service. Optimization practical strategies are glycemic control to target the HbA1c to be less than 7% for elective surgery. If it is more, delay the surgery. Send them to an endocrinologist, get the sugars controlled, get the intraoperative glucose less than 180 milligram for optimum results. Smoking cessation, in India, we can tell the patients to actually stop completely, but probably in the West, they may say that we are encroaching into their personal space. So that may be a problem. But ideally, smoking cessation, stop, not reduce. Absolutely stop it would be what we should be telling the patient. Minimum 4 weeks before surgery. It reduces the risk of surgical site infection by about 30 to 50%. Nutritional assessment, all surgical patients should be screened for it. We should have an albumin more than 3.5 grams for best healing. If it is not very good, meaning you can wait for about 7 to 14 days where you can improve their nourishment states. But when you look at it from an infection control point of view, there is no actual record which says that if the patient is having hypoproteinemia, there is an increased chance of infection. Though logically, the wound healing becomes poor. Nasal colonization the patients should be screened, especially the MRSA patients. If they are there, mupirocin ointment should be applied in the nares twice daily for about 5 days preoperatively, and a chlorhexidine body wash is recommended. The antibiotic prophylaxis, this is the gold standard, especially because most of our patients are the class 2, that is the clean contaminated wounds. So the timing is within 60 minutes before incision. Now, the problem is that who will give it? Ideally, the anesthetist. Because if you say you're operating on the patient and on one patient, you're asking the next patient to come, chances are that there may be a delay in the first surgery. And if you ask the ward sister to give this injection, the procedure may be delayed and the timing may have changed. So ideally, it should be an anesthetist giving this at least 60 minutes before incision, because they can time when the anesthesia would be if you're giving vancomycin or fluoroquinolones, itself is the most critical factor. So what you can give, any of the cephalosporins. For colorectal procedures, you can also add metronidazole. If there is MRSA risk, you can add vancomycin, but ideally the vancomycin is a reserved drug and is to be kept in reserve unless absolutely necessary. In patients having beta-lactam allergy, clindamycin can be given. So the duration for almost 80-90% of the surgeries, 1 dose of preoperative prophylaxis is enough. But if the procedure extends beyond the half-life of the antibiotic, that is more than 4 hours, you may have to redose. But if the procedure is going on beyond 8 hours, 12 hours or more, and you have to give 1 more dose, then the problem is if you give more than 2 doses, the antibiotic is not now prophylactic, but it becomes therapeutic, more than 2 doses. So the antibiotic prophylaxis is only 1 dose or a maximum of 2 doses. More than that becomes therapeutic. So the common mistakes that happen are prolonged post-operative antibiotic. There's no benefit at all in this, especially in the clean contaminated or the clean cases. Wrong timing, giving the antibiotic too early or after the incision, because it is at the incision that the shower of bacteria comes into the blood. And at that time, optimum dose of antibiotic should be in the bloodstream. If obese patients are there, the dosing may become inadequate, and that also is a problem. So if you are doing long procedures, you may have to give a second dose. If it is not given again, the problem is the half-life of the antibiotic goes off and chances of infection becomes high. So the skin preparation, Mastrocola et al., they have proposed that the preoperative showering should be done. It should be done in the night before and the morning before surgery using a chlorhexidine gluconate solution. It is said to reduce the skin bacterial load by over 90%. Hair removal, again, is an important thing. The hair removal, like we said before, do not use a razor. It is always only a trimming that is required, because shaving increases the SI risk by almost 2 to 3 times. Okay, a simple wash preoperatively is more than enough, and this is exactly what 𝐒𝐤𝐚𝐥 said long back. I think in the 18th century, a gynecologist, uh, he said that a simple hand washing that is done reduces puerperal sepsis. At that time, it was 80% mortality to less than 2%. This is what we are also trying to say even now. So best practice for operative site preparation is again chlorhexidine alcohol. It is superior to povidone iodine as per multiple RCTs that have been done. Okay, so what you're going to do is that you're going to paint and paint for about 2 to 3 minutes. This timing is for the antibiotic to act on the skin. What is done is to paint the incision first and then go in circular or back and forth movement progressively away from the incision. So when you're painting, the important thing is that you should not be painting from the periphery towards the center, but rather from the center and outwards, never coming back. Otherwise, you're tending to get infection inwards. Povidone iodine is a good but a slightly lesser alternative to chlorhexidine solution. So intraoperatively, like we said earlier, the core temperature we want to maintain is about 36 degrees. What you can do is forced air warming or give warmed IV fluids. Now, problem with hypothermia is that it reduces the immune function and tissue oxygenation, which hampers wound healing. Glycemic control, again, target is between 110 and 180. If required, we should be using an infusion pump at major surgery. If hypoglycemia is present, again, this is a big problem. The surgical technique, minimize tissue trauma and devitalization, meticulous hemostasis, minimize the use of foreign materials, use drains appropriately. But the thing is, these drains are not to be kept for a long time. Again, it invites an infection, preferably remove it early. Operating room itself, minimize traffic. Those necessary for the surgery alone need to come. We don't want a lot of people who are not involved in the surgery to be in the operation theater. Maintain positive pressure ventilation. It is said that in the operation theater, the pressure should be slightly higher than the outside, so that even if a door is opened, there is no entry of infected air from the outside to the inside. Similarly, the temperature of the operating room also, it should be 1 degree lower so that the air moves from the cooler to the hotter outside. Wound closure, it is by three. Usually occurs either as a primary closure, especially so in the clean and the clean contaminated wounds. Here, the chance of wound infection is, like we said, about 1 to 7%. Delayed primary closure should be considered for contaminated wound. But the thing is, like we said earlier, there is a more than 2 to 3 times increased risk of wound infection. Delayed primary closure usually is done about a week after the original surgery, waiting for the the edema to settle down. But when the wound heals by secondary intention, the chance of wound infection is more than 50%. The closure materials that are used are monofilament sutures are preferred because in a monofilament suture, there is less bacterial adherence. It doesn't stick to that. Subcuticular sutures are way better for reducing surgical site infection as compared to a stapler, but staples can also be used for face closure. Now, in difficult situations, a negative pressure wound therapy is recommended, especially if you have a high risk wound. If it is an obese patient, a contaminated wound, or a high tension wound, like in an incisional hernia, or you have a infected wound, or you're closing it secondarily and there is tight and the wound is under high tension. So this on the right side is the Previna system. It is a NPW. It's a negative pressure wound therapy system, which can be used for about 5 to 7 days in 1 or 2 settings. What it does is to pull the two ends of the wound together, reducing the tension at the wound edge. It actually reduces the lymphatic occlusion that happens in that area, the lymphatic stasis that occurs, and also improves on the blood flow in the local area, thereby increasing the chance of wound infection. Actually, this is a system, I think in the West it is very popular. In India, it has just come up now. It gives very, very good results, especially in difficult wounds. So post-operative surveillance, inpatient monitoring for in the first 7 days, what you want to do is to inspect just see the wound if it is okay. Monitor the temperature, pain assessment, check for WBC, CRP if indicated. If there is any change, it would indicate that there is an actual infection happening. Outpatient surveillance is after the discharge period, 8 to 30 days. You can tell the patient what are the warning signs, especially the redness, the increased temperature, pain that may increase, pus that may come up. Now, if it is there, they are advised to come back immediately. In high-risk patients, we can even phone up the patient, ask them if they're okay. Okay, now there are a lot of electronic surveillance systems where the patient can actually, we have apps which help the patient communicate with us with photographs as to how their wound is behaving. So the warning signs are increasing pain or tenderness, redness which spreads from the incision, warmth around the wound, pus which comes out, if there is fever, and if the wound is separating. Now these are early warning features which say that the patient has a surgical site infection. So if present, the strategies are how to detect this is by having standard assessment tools, nurse-driven protocols, patient engagement education, and telemedicine for remote follow-up, like I said earlier. So for a wound, suppose there's a wound and we are seeing the patient having a wound infection. First thing that we want to do is how severe is the wound. So for that, we have wound infection grading systems. Lot of systems here, I've shown 5 of them. The NERDs and the Stonies are especially useful where diabetic foot wounds are concerned. For superficial topical infections, the NERDs criteria is good. For the deep or spreading infection, the Stonies criteria can be used. And this determines how severe or how bad the wound infection is. Where you want to actually audit the surgical site infections, the asepsis scoring is a very good option. The asepsis stands for additional treatment, serous discharge, erythema, purulent, exudate, etc. And it is scored from 0 to about 60, and more than 40 indicates very severe infection. The Southampton grading again is a grading system on a daily basis. It can be done. The wound is graded from 0 to 5, where 0 is normal healing, 5 is where there's deep or severe infection, and 4 is deep or severe infection, 5 is when the infection requires a surgical intervention. So it's a grading actually, and each of these in turn is again graded as A, B, C, D, depending upon the percentage of wound that is affected. So what will you do? If there is superficial infection, it presents as erythema, purulent discharge, and it happens in the first 4 to 7 days. So what will you do? Assess the wound, examine it, and first thing is to rule out deeper infection, because if there's a deeper infection, it is a deep surgical site infection. Now, the thing that we can do is to lay the wound open, okay, and examine the wound and see if there's some amount of fluctuation present. Remove skin sutures as needed, and whatever little pus is there can be expressed. You can probe the wound gently with a mosquito or a forceps. It should not be that we are going to poke into the wound and create false cavities. Just gently probe so that whatever discharge is there comes out. If there is discharge, pack the wound with saline moistened gauze if you think that the wound is clean. But if you think that there is a little bit of infection or edema still present, you may use alginate dressings, especially silver or such, which are coated into that, which will give an additional antibiotic cover. The alginate is excellent for uh, for pulling in the moisture and edema, etc. Now, when you're giving these special care dressings like the calcium alginate dressing, it can be kept for up to 2 to 3 days in one sitting. If it is not there, we may have to do daily dressings change the dressings on a daily basis. The wound that is opened may have to be left for healing by secondary intention. And if it is a difficult wound, like we said earlier, we can consider negative pressure therapy. Antibiotics for a superficial infection is not always necessary. Okay, but when you have cellulitis, which is involving more than 5 centimeters of the incision, or if there are systemic signs, immunocompromised patients, or if the patient has significant comorbidity, their antibiotics may be started. So the selection is going to be initially an empirical antibiotic. If you suspect MRSA, you may give doxycycline or cotrimoxazole, etc. But then once the culture report comes up, the antibiotic has to be based on the culture result. For deep infections, the diagnosis is essentially by clinical assessment, and in this case, you may have to do an imaging. For the superficial, it's only clinical assessment, but for the deep infections, you may need an ultrasound or a CT, which can determine the extent of the infection, the depth of the infection, whether there's an abscess, etc. And it may also show you the facial involvement. Deep infections generally require surgical exploration. So by surgical exploration, what we're saying is we open the wound, determine the tissue involved, whether it's the fascia or the muscle, what is involved, how much of it is involved. Then sometimes the muscles may be necrosed and may need a lot of debridement. So this may need to be done. So when there is deep infection, the source control becomes mandatory. The source is usually a suture, or it may be some necrosed tissue that is there because you put a suture too tight or something may have happened. In a deep infection, IV antibiotics is mandatory. Okay, it may be 7 to 14 days adjusted by cultures. And when you have deep infections, you can leave the wound open, keep dressings for some time, but a vacuum assisted closure actually helps faster healing. Organ space infections. Now here, the skin and the deep tissues may appear to be normal, but the patient has systemic manifestations, fever, IBS, abdominal pain, etc. Diagnosis for will require CT. It's actually the gold standard here. And treatment, unlike the superficial or the deep infections, when you have organ space infections, you will need a multidisciplinary approach because a lot of organ systems may be involved, and treatment for each of these, the failure of each of these organs may be handled separately by the experts. Source control is mandatory, which may be percutaneous drainage or open laparotomy drainage, etc. Initially start off with a broad spectrum IV antibiotic and then give culture-directed therapy. In a deep-seated infection, you may need a prolonged treatment, meaning maybe 14 to 21 days, up to 3 weeks or more. So the empiric antibiotic regimens for intra-abdominal, if suppose an intra-abdominal organ infection is a piperazine, tazobactam, or carbapenem, if there is risk factors, you may have to give an anti-MRSA coverage. So when you have a very high risk patient and an organ space infection, you may have to consider giving antifungal therapy also, because these are all immunocompromised patients. So when you have organ space infection, you may treat it in the ward, but invariably you may have to take it to the operation room. When do you take it? When there is a failed percutaneous drainage, when despite antibiotics, you've given antibiotics for about 10 days, 15 days, and still there is ongoing sepsis. If you see there is a definite facial dehiscence, if the fascia is opening up and the organs are coming out of the wound, this is a definite indication for taking the patient to the operation theater. And if there is a necrotizing infection. So in a deep or organ space infection, source control is mandatory. Unless it is controlled, no matter how many antibiotics you give, the patient is not going to heal. So it may have to be aggressive source control, debride, excise, sometimes even resect part of the organs, because otherwise this infection does not get better. And for both these things, multidisciplinary team involvement becomes very, very important, because all these patients have multiple organ systems which are involved. They may have immunocompromised, they may have diabetes having already caused a cardiological or a renal compromise. So in special populations, what do? Diabetic patients, strict glycemic control, keep it under 180, increase the surveillance, meaning lower threshold for imaging. If you think in a patient having diabetes, you think that there is an infection, you can think of doing some form of imaging early. You have to keep a lower threshold for imaging, and always consider endocrinology consultation, because sugar control is mandatory. Like I said before, in preoperative, intraoperative, or in the postoperative phase, it is always the sugars which need to be kept under. Hyperglycemia is bad. The second set of patients is the immunocompromised patients, where you may have to give a broad antibiotic coverage initially itself, and will need early aggressive intervention wherever there is infection, because otherwise this infection may flare and the patient may go into sepsis. So, like I said before, any immunocompromised patient with an organ space or a deep infection, you should consider opportunistic organisms, and it's better to take an infectious disease consultation. The next set of patients, the obese patients, where dosing may be a problem. You may be giving an antibiotic, but the dosing may not be correct. So appropriate weight-based antibiotic dosing is mandatory. Consider the NPWT for these patients, because for them, the lymphatic drainage is poor, venous drainage is poor, and chances that edema fluid collects in the local area is very, very high. So if you think that there is organ space infection, deep surgical site infections, management using NPWT actually helps. In elderly patients, problem is they do not respond as well as the younger patients. They may have very subtle presentations. With very severe infections, they may have very little manifestations. So we should be very, very aware if they have problems and keep a low threshold for intervention. Adjust antibiotics per renal function and increase their nutritional support. So these are candidates for the ERAs. Do not keep them underfed. Their nutritional support should be enhanced. If there is prosthetic or implant infections, always consider salvage or removal. And when there is prosthetic implants, there may be biofilms which forms, and biofilm is a very, very bad thing, especially in a diabetic wound. So you should consider major debridement if there is biofilm. I think every time the patient comes to the OPD and you're looking at a wound, even if there's a small thin biofilm, it needs to be removed, because once it is removed, the granulation is going to be better. Infection rates are lower and the wound healing is much faster. So prosthetic implants, you may have to prolong their antibiotic therapy. And if it is infected, you may have to consider involving the infectious disease or the orthopedic and other surgical teams for necessary intervention. So two of our patients here, one patient recently that we've operated, an 84-year-old male, we have done a bilateral inguinal hernia mesh repair with the whole for a prostatic hypertrophy. Now, this patient actually had type 2 diabetes. He's a known case of atrial fibrillation and has chronic lung disease. Now, the thing is, if you look at it, this is a clean case by itself. It's bilateral inguinal hernia, but the intervention for the prostate, that makes it a clean, contaminated surgery. And that was done because the patient had UTI. So what we did, prevention strategies were, meaning we delayed the surgery for optimization. Initially, we got an endocrine consultation for control of sugars. We got a pulmonology consultation for nebulization, etc. Urology was consulted for the prostatic hypertrophy, and they decided to do the column. Now, since the patient had UTI, we got the infectious disease also to come in and treat the patient for the UTI for about 3 weeks prior to the surgery that we did. So preoperatively, chlorhexidine shower the night before and on the morning. We did, meaning this is an 84-year-old male with very little hair that was there, so we didn't need actual hair removal for this patient. The patient was fed till late in the night, and we did this surgery early in the morning. Immediately following surgery, patient was taken. I think about 2 hours later, patient started feeding. And since he had atrial fibrillation, we had to give him IE prophylaxis also. The antibiotic prophylaxis was cefuroxime 1.5 grams, which was given 30 minutes before incision. In the operation theater, his temperature by forced air warming, we maintained at around 36.5 degrees. Glucose was maintained around 145 by the anesthetist. And as part of pain control, epidural analgesia was also given to the patient. In the post-op, unfortunately, the patient had another AF, and the cardiology people, they said that apart from amiodarone that they were giving for the atrial fibrillation, the patient needed to be started on anticoagulation. But the urologists were against that because they had done a laser ablation. HoLEP is a laser ablation of the prostate, and it was an open wound with high likelihood of bleeding. So if we give anticoagulation, the patient will have bleeding in the urine. So they said no anticoagulation. So we had to keep the patient monitored in the ICU for 2-3 days, at which by continuing with the standard wound care. Now, the outcome was this patient actually had a very uncomplicated recovery despite all these things. At 8-day follow-up, the wound was okay. Patient actually started walking despite all his problems. From the second day, he was walking around. He was very, very happy. You can see this patient here, very elderly, frail gentleman, but he was mobilized. He went home walking comfortably. The second, so the first was study is the, I would say, clean and clean contaminated. How do you manage? So this is a patient with a diabetic foot, uncontrolled diabetic with CKD on hemodialysis and coronary artery disease. Patient came with an infected callus in the right little toe with the purulent collection extending to the plantar aspect. Now, there was suspicion of a Charcot's foot also on evaluation. So initially what we did is we localized the, plantar, it was a deep plantar abscess which is extending from this callus which had to be opened out. And this, there was another secondary cavity which was there which caused a secondary wound there. Pus was drained and the necro tissue was debrided. So at initial admission, we gave a broad spectrum antibiotic. It was Magnex, which was given for 5 days. Initial pus was sent. And based on the culture report, it was actually E. coli sensitive to cotrimoxazole, doxin, linezolid, tigecycline, etc. And there was a multi-drug resistant Klebsiella, which is sensitive to colistin. So then he was changed over to culture-sensitive antibiotics as per the infectious disease team and the nephrology people who were also involved because of the hemodialysis. Now, deep plantar space was laid open and a thorough wash was given. And we had used, in this patient, we had to use multiple things, including serial debridements. We had to give him two sittings of NPWT, which was changed once in 5 days. Now, after this, actually, the patient was on ErgoClean and PHMB, which is used as in serial for improving the granulation and all that. Always maintaining glycemic control. And once the patient's wound healed, now we have asked for an offloading footwear. The outcome is that in about 3 to 4 months, the patient achieved complete epithelialization. So you can see here the wound starting and till the end. So when we have say surgical site infections, it is always better to have safety checklist, preferably the WHO checklist, which has everything that we said, the bundles. You should document the antibiotic timing in medical records because, like I said before, if there's a surgical prophylaxis, it has to be at 60 minutes. It cannot be way before or at the time of incision. Involve patients in their care. So you have to tell the patient what you're doing, why you're doing, make them call back to you if there are minor issues. Monitor and provide feedback to the surgical site infection of surgical to the infection control team. That is what we are doing as part of our infection control training program here. have standardized protocols. So it can be as per the hospital, as per your own local things, whatever is available. And like we said, use bundle approaches. It has to be all 6 of them together. It cannot be any one small part, because it is a patient you're going to treat right from pre-operative to post-operative till the time that the wound heals. And do not hesitate to engage multidisciplinary teams. Where required, you should engage all of them, because they would be better at modifying treatment protocols. What you should not do is don't give antibiotic because beyond 24 hours, because then it is not prophylactic anymore, but it becomes therapeutic. Do not shave surgical sites. It is always clipping. This is one of the most important thing, that the message that we want to go from here, because otherwise micro abrasions can cause wound infection. In obese patients, it should be weight-based dosing. Don't skip preoperative optimization for convenience. Just because a patient has come from Dubai to India and has to go back in a week does not mean that you will not do the the optimization just because they have to go back home. It is going to increase infection. It is going to increase the cost of treatment for the patient. Don't ignore intraoperative hypothermia, because again, it reduces blood flow, reduces immunity. You should be treating an infection of the wound and not colonization. Simply getting a colonizer which is affecting the wound does not mean that the patient has infection. Look for signs of infection, inflammation that may be present. Okay. Where there is a heavily contaminated wound, do not close primarily. It can be a secondary closure after about 5 to 7 days. So these are the guidelines that we have used here. Take home messages: optimize patients preoperative, no smoking, good nutrition, sugar control, antibiotic prophylaxis, chlorhexidine alcohol for skin preparation, never shave, use clippers where necessary, maintain normothermia, control intraoperative glucose, a meticulous surgical technique, prophylactic antibiotics for 24 hours only, not beyond that. Ensure 30-day surveillance and follow-up. Drainage first, antibiotics later for superficial surgical site infection. Thank you. So,
Thank you so much, Dr. Riju. That's one of the most comprehensive lectures I've heard about surgical site infections. Thank you for enlightening us. That's really very educative and very, very comprehensive. Thank you so much.
thank you, sir. Thank you.
I think there are a few questions. If you have time, we could probably answer that.
Yes, yes, doctor.
If anybody wants to ask any questions or clearer doubts, you can put in the Q&A box below, please.
Yes. In the chat box, there was only one question. I think Mr. Rajaraman have answered for it. Am I right, doctor? Like, can I bring up the question again from the chat box?
Sure, sure.
Yeah. So it is like, question is lost. I think they have removed that question.
Stella, it's about how many times pre-operative
Yeah.
shower should be given.
Yes, yes. Thank you, Mr. Raja. Yeah, that was the question, doctor.
Chlorhexidine bath, how many times it should be given? That was the question, yeah.
2. One on the night before and one on the day of surgery, preferably.
And there is another one question from the Q&A portal, like what is the best practice in cleaning deep surgical site infection by using hydrogen peroxide?
Actually, for quite some time, for all these deep wounds, using hydrogen peroxide and betadine was considered quite okay. But now, many of the wound care associations do not recommend betadine hydrogen peroxide, actually, because it seems it actually can affect granulation and wound healing. what is preferred is some of these cleaning solutions that are available now, newer cleaning solutions. I think octinitin is one of them. There is PHMB, something called as Milcept, which can be used for cleaning. But ideally for all these things, the surgical cleaning is always recommended. If there is a unhealthy tissue, necrotic tissue, there is pus, it needs to be drained before using any of these solutions. They're all adjuncts, the solutions that may be there, but the primary surgical treatment that is in there should always be done. There is nothing second to that.
Yeah, I think plain old saline is much better than betadine or any of those things. Hydrogen peroxide, I think, no, I know the guidelines are against it. Personally, I use it very cautiously when there is especially in trauma, in clearing the dirt and debridement, just for a one-off use. But most countries have banned it actually.
So there is another question, like, is it preferable to use betadine solution for cleaning the skin before the incision? If no, then why?
See, the recommended thing is the chlorhexidine solution only. What is recommended? Betadine is also, meaning it is as a second choice, maybe yes. Even now, many centers, they do use it, but not, meaning I wouldn't call it a recommendation, but still many people use it.
I think there are a couple of questions in the chat box, Stella.
Yeah. So what is the standard benchmark for SSI? So this is one question from the chat box I've picked up.
Meaning?
I think you already explained it, for the different type of wounds.
Yes.
It depends on the surgery, what you're doing, and which part of the body is being taken care of. So it may be a superficial or a deep or a organ space infection. I'm not sure what the benchmark means. If you're thinking of it as an infection, the important things that you want to look at is the timing after the surgery. Meaning it should be within 30 days. There should be evidence of infection or inflammation, meaning all the cardinal signs of inflammation should be there. There should be pus drained, or there should be a dehiscence of wound. And if possible, you should be able to culture an bacteria or something from that. So these are all benchmarks. If it is there, then you can definitely call it as a surgical site infection. So it will depend on, where is the site, whether there is one of these symptoms and signs. Because actually, what they recommend is for each of these things. I couldn't go into that because it takes time. For each of these things, if you're looking at the superficial or deep wound infections, so there are 2 or 3, primary requirements and a few multiple small requirements, which should be met before you actually term it as a surgical site infection. So the minor criteria and all are like, something like the surgeon saying that there is a surgical site infection, or that there is a pus drain from the wound, or if the total count is elevated. All these are all minor criteria. But the primary criteria is about the location and about the fact that there is an infection.
And there was another question, like, so for maggots removal, which solution is recommended?
We use turpentine oil. Anything that is pungent can be used because you want that to just come out.
I think the thing is to do it repeatedly. That's the thing.
Oh.
In badly infected wounds, actually maggots is a good thing because these maggots actually clean up the wound, debrides the wound very well. You need not fear these maggots.
Yeah, when I was working in the UK, you could actually use 1-800 maggots to buy maggots and put them on the wound, no dirty wounds.
Okay, there's one question in the YouTube. What is the prophylaxis before angioplasty? I think, yeah, we can hold on with this question, Ms. Anushka Agarwal. Like next week, we have the cardiothoracic specialty doctor who's coming up. And another question, I think, if episiotomy is done on gynec patient, if
The
it's got
prophylactic
infection-
antibiotic will not change because you're only looking at it as either a clean wound, a clean contaminated wound, or a dirty wound. If you are not encroaching into a body space, a body cavity, where there is infection, then it's a clean wound. If you are encroaching, if you're going into the body cavity, let's say the abdominal cavity or the lungs or the chest or the gastrourinary system or the gynec organs, there it becomes a clean contaminated wound which needs an antibiotic. But where it is clean wounds, you don't have to give an antibiotic at all.
Thank you for the clear definition, doctor. I think everybody would have got benefited out of this. And there is one more question, which is always a repeated question. I think I can answer it for this. If episiotomy, whether it is considered to be an SSI, if it is got infected, yes. So
No,
that's
see, the thing is, when you're looking at it as a superficial wound, because episiotomy wound is said to be involving the skin and the muscles is what is thought, but actually technically does not fall into the superficial wound. It is more of a deep surgical site infection.
okay. Thank you, doctor. This is most repeated question whenever we take up this session related to infection prevention and control. So I think I've done with the YouTube questions, and going back to the Q&A portal. Okay, so some surgeon use betadine solution plus chlorhexidine solution to clean the skin. Which solution can be used first?
I think you have to clarify this practice of using two solutions.
Not recommended, actually. I don't know why they're doing it. No, either one is enough.
I think some people use betadine and then they use sterilium to clean up the betadine, no, all sorts of
Yes.
things. So no, all that is not recommended.
You want the solution to be on the skin surface for about 2 to 5 minutes, which is the time it takes for that solution to act on the bacteria, local bacteria. So you want the bacteria within the pores, within the cells to also be taken care of. It takes some time. That is why you're painting about 2 or 3 times. It's the time which is more important than how many things that you're using.
Yeah, just stick one solution, preferably chlorhexidine. That's the message.
Okay.
Yeah, I think most is a repeat. Is there anything else?
Repeated questions. So I'm just skipping off those questions from the Q&A portal, and so one of them have asked about how to perform a dressing for whom those who perform a brain surgery like craniotomy. Do you want me to take it up that?
Yeah, I think it's an important message there. I think the question is patients who had a craniotomy or craniectomy, which antibiotic solutions should we use?
Antiseptic solution.
Yeah, that's the reason I'm asking you that question. Yeah.
It's pre-operatively or post-operative, because the thing is, whenever your pre-operative preparation would have been the same. In the post-operative period, you want the wound to be kept closed for a minimum of 2 to 4 days, and beyond that, it's actually a matter of choice whether you want to keep the wound closed or open. I think personally, I would after 48 hours, I prefer to keep the wounds open.
Yeah, I think in our country, it's a better approach, with all the humidity and sweating. Yeah.
Because all wounds are going to heal by their blood flow and not because of the antiseptic solution or the dressing. The scalp is one of the most well perfused areas. So if you have a wound there, it heals very well. It's in the other parts of the body where there are issues.
Yeah, I think with team all have got answers for it. I think I've done with the questions, sir, from the chat box. And
Yeah, repeatedly, there is questions
yes,
on chloric.
yes,
Is it okay? Chloricil.
yes, yes. So I'm
So you
skipping
repeated in.
questions. Yes.
That's why, I think the evidence is very much for chloric,
Chlorhexidine.
but the tradition is very much for betadine. That's a problem.
And someone have asked for the spillage class. Yes, it is well noted, and we'll take it up for another free webinar session. So in future session might be. Okay.
Over to you, Rajaraman.
Yes.
Nothing more, Doctor. I think, Dr. Riju, thank you very much for the deep. I think the number of hearts and thumbs ups are or indication of an excellent session. So thank you very much for being patient and answering all the queries. Thanks, as usual, Dr. Pari. I think you did a phenomenal coordination. Thanks, Dr. Stella, for being there and managing time and connectivity, everything. Well done.
Thank you.
Thank you very much. Thanks to all the participants. I hope on the Diabetes Awareness Day that we had a lot of ideas and to take care of these challenging cases from Dr. Riju's knowledge and experience. So with that, hand over to you, Stella.
So thank you so much. And Doctor, I have a couple of announcements at the end, and so shall I proceed with that?
Yeah, I think you can excuse Dr.
Yes.
Riju. Thank you so much, Dr. Riju.
Thank you.
Again for the
Thanks for the
wonderful lecture and very, very informative and comprehensive. Thank you so much.
Thank you.
Thank you, Doctor. So
there was some comment on the link. Maybe you should just
yes, I'm going to come up with a slide with a detail.
Can I excuse myself because I got
Sure.
getting late from my clinic?
Yes, yes.
All right, yeah.
When Mr. Rajaraman, even you can go ahead, so that we'll have this announcements get over, and then we'll wait for the participants to get the Zoom room off.
All right. Thank you so much.
Thank you, sir.
Thank you.
Thank you. So, dear all participants, this is our November calendar. As you have seen, we have completed this 14th November session today. And we have two more 𝐒𝐿𝐾 series in this November, which will be on 21st and on 28th. And on December 5th, we have the 5th webinar of the 𝐒𝐿𝐾 series. And this is the online CNE calendar. Related to this, if you want more detail, you can contact our admin manager. And as we have announced last week, we have planned to start a new webinar series, the free webinar series for the infection control nurses. So all the nurses and the leadership level, administrative level nurses can participate in this webinar, and you can ask the question with our expertise speakers who are going to come up, and we'll share the flyer soon in our webinar groups and in all our ICN groups. Even the topic is going to be on how to investigate an outbreak, a step-by-step approach. It's not going to be a theoretical webinar. It is going to be a implementation challenges what you have in your healthcare system. And so meet our next week's speaker, who is Dr. Anand Tirtha. He is a chief cardiothoracic surgeon, Ramaya Hospital, Bangalore, and he'll be dealing with preventing SSI in cardiac surgery, lessons from the heart team. So stay tuned with us for the next week webinar. And about the newcomers who have come today asking for the link. So we have changed the method of providing the webinar certificate. So a quick update about that. So we'll not be giving you the link in the chat box as we were doing initially. So from last week, we have started this new method of delivering the certificate. So tomorrow after 4 p.m., that is exactly after 24 hours of completion of today's webinar. So tomorrow after 4 p.m., check either your inbox. If in your inbox you have not got any feedback link from us, you can check your spam box. So you will get the feedback link directly to your mail IDs, which is you have used to register for this webinar. So fill that link, and within less than 10 minutes of time, you will get the certificate for the participation for this webinar in your device. So this is the change we have brought up for this webinar. So we will not be having any link in the chat box. You will get the email from SkillsforMed official ID. You will get the feedback link in your mail inbox. If you have not received, I repeat, you can check in your spam box. Still you have not received attending the program, you can contact our admin manager. She will help you out. So fill that form, and within less than 10 minutes of time, you will receive your certificate. So this is the new update. And I'll leave off this page here for all your participants who still want, have not logged in with our WhatsApp community. So you can scan this QR code and you can join our WhatsApp group, where you will get all the course informations, flyer, and what are all the programs we are running, and what all we have, and much more engagement activities and interesting things are there in the WhatsApp group. You can join our WhatsApp group by scanning this QR code. And this QR code is about the infection control nurse course program. Register for this program. This is actually the offer sale is running. So just who all are aspiring to become an infection control nurse in your administration, you can scan this QR code and avail this opportunity immediately. So thank you so much. We'll see you on next Friday. So this page will be there until everybody is leaving the Zoom room. Once you have registered and once you have scanned this QR code and you have not been in the WhatsApp group, you have entered into WhatsApp group, you can leave the Zoom room so that we'll understand to close the close this session. Thank you so much. Thank you for all your presence.